And thanks very much for organizing the conference. The subject matter is clearly an important one, and clearly one that warrants a lot of discussion and a lot of exploration, and even more importantly, a lot of action in institutions like ours and yours to implement new ways of doing things. And I also want to thank and congratulate the VA on all their work. We have known of that for a long time, and have watched and learned from their experience, and you'll see a lot of reflections of the VA program in Lexington in our experience. And as I say, it's been a great help for us to go down the same challenging but absolutely essential pathway to taking better care of patients. So with that, let me, before I start, give you a little bit of flavor of Cincinnati Children, for those of you who may not know it. Let's start. There we are. That's where Cincinnati is. We're there basically in the middle of the medical concentration in town. Our primary market areas are southwest Ohio, southeast Indiana, northern Kentucky. The green states that you see surrounding us are generally viewed as a secondary market area, but the reality is the source of patients is literally global, and the reach and engagement with various programs around the world is very substantial. We're an academic medical center under an affiliation agreement. We provide the University of Cincinnati College of Medicine with its Department of Pediatrics. All of our physicians, all the physicians that work at Children's are employed by Children's, and the university supplies faculty appointments so that their academic credentialing and so forth comes through the university. But we are completely independent from the university. There's no cross-governance organizational structure. Our connection is really through this affiliation agreement and the pursuit of topics of common interest where we both very much want to accomplish the same thing. Organization over the years has expanded at a fairly rapid clip. We have about 15 locations around the city. The newest one is in Greene Township. The largest one is in Liberty Township. And the others have evolved really over the last 20 to 30 years as service to the area required it and enabled us to basically take better care of kids where they are and not require them to come down to the main facility. The facility itself at its central location looks like this. There are a couple of buildings that are not in the picture. They're also part of the organization, but it's really grown quite rapidly over the years. And the net result is today it's one of the largest, most comprehensive pediatric medical centers in the country, and pretty much by any measure, it is the largest pediatric hospital in the country. We have 598 registered beds, and 565 are in use or available for use. And I just looked at the data this morning, and we're operating today at 93% of capacity, as a census that's really, literally an all-time high. So it's a very busy place, very engaged place, and one that has lots of beds and all the infrastructure to support that. The U.S. News and World Report has us among the top 3 pediatric hospitals in the country, and we're rated among the top 10 in each of the 10 specialties that they rate. And we offer everything from primary care for training purposes. We don't own pediatric practices in the community, but we do have a primary care function that's generally in at-risk neighborhoods where We train staff for future roles in primary care. One of the unusual parts about Cincinnati Children's is it has a major investment in mental health services. Almost a quarter of our beds, somewhere between 20 and 25% of our beds, are mental health beds, so both a residential facility and at the main hospital. So we have a very robust investment in that very critical area. And of course, the broader range of complex medical care and surgical care is included. And in our last fiscal year, we took care of kids from all 50 states and 53 different countries. And one of the most interesting descriptive statistics to me is that our employee group, which numbers about 15,000 now, represents 95 different nationalities. And there was a time when I probably didn't think there were 95 different countries from which people could come, but indeed among the employees are those 95 different countries, and we have a result of that a surprisingly significant visa management function in our HR department that keeps track of the visa requirements for all of these individuals. I was CEO there for 13 years, and during that time, one of the characteristics that described the place was one of rapid growth, and we grew at somewhere a little bit over 15% a year annually for that 13-year period, and that's measured by revenue. And we did this really without a specific growth strategy. That was never our intention. Our intention was to improve child health and improve the care that we provided with kids. And as that got better and better, the rate of growth every year during that period of time exceeded what we had forecast. Quick summary of comparative statistics over the 1996 period when I first arrived as CEO to the 2013 period. As you can see, it's again a substantial operation and one that's grown quite a bit. And I should say, just on a personal level, I have a checkered past. I'm not a normal hospital CEO. Principally, my career was devoted to practicing law in a large law firm in Cincinnati, mostly business law and in various firms or forms. And I left the firm one other time to become the president of U.S. operations of kind of a small industrial company that ultimately was sold to Emerson Electric, and learned a lot about manufacturing processes as a result of that experience. And if I look back on what was the most useful part of my education in working on transformational issues in the hospital, pretty clearly it was the manufacturing experience I had, particularly during the Emerson Electric ownership period. I joined the board in 1979 as a kind of a standard community representative. Ended up being chairman of the board in 1992, and then in 1996, to my surprise and the surprise of lots of people, I got demoted and became CEO. And so this whole process of what I brought to the organization is not one of someone acculturated in the medical community. And really, when I started, I had scarily little understanding of how healthcare worked and how the standards and expectations that prevailed really got started. And so the good news in that is that I had certainly had an open mind. The bad news is I needed a lot of help to try to figure out what was going on and how we might change it. It was an interesting adventure. pursuit of that the organization embraced was really the vision, or embodying the vision that we put together. And we adopted that in 1996 after a 2-year debate, discussion that was really very rich and very helpful. It certainly was to me at that time, and also certainly in my time as CEO. At the time we did that, I was the board chair and had the opportunity to lead the process, but the real contributions came from the senior faculty, senior business individuals, and trustees who had a chance to reflect on what this organization really was, what it could do, what it should do, and what it should commit to over the next chapter of its institutional life. And the reason we engaged in that process was quite simply that I asked myself and other trustees when I was board chair, what were we doing? What was our business? What were our activities? What should we be doing? And all of us, almost to a person, would come back and say, well, we're in 3 businesses: research, clinical care, and education. And we all knew that and understood that and watched it with some care as it evolved. But none of us could put together a single statement what our overarching purpose was. How did these 3 activities connect to some purpose in life that we as a complex institution should acknowledge and should influence the direction of each of those 3 businesses, both as they each operated and also as they connected with each other to accomplish some purpose. So out of that collective inability, we went through this process of coming up with a vision statement. And as I say, it was a rich experience. And one of the most interesting parts was there were a lot of stories told by the people who had been around for a long time about what we did well, what didn't seem to work very well. And one of the observations was that we did some things really well, but most things we were kind of mediocre in. They were undistinguished. And we couldn't figure out why, if we could do some things well, we couldn't do more things well, if not everything well. And the central story that I think moved all of us the most was about Dr. Albert Sabin, who did his work there and came up with the Sabin oral polio vaccine. And we basically said to ourselves, well, if we have the kind of environment that could spawn that sort of creativity and favorable impact on pediatric health care, what do we need to do in order to do that everywhere? Why shouldn't that be our universal aspiration for everything that we do? And the more we had the discussion, the more we became comfortable with a much more limitless horizon and one where we could be very aspirational, very ambitious to do good things, recognizing that we had a long way to go to really be able to say to ourselves we were successful in that endeavor. But nevertheless, the endeavor was a very important one, and one that we ought not to shy away from. And I found over the years that having a clear, well-grounded, aspirational, unambiguous vision for the organization was really something that made an enormous difference in how we operated, in how we conversed with each other, in the kinds of things that became legitimate opportunities to pursue. And it basically made the frontiers of pediatric health care all available to us to contribute to. And with consistent contribution over time, hopefully provide some leadership in those areas. And we discuss the vision even today all the time, and it's really the litmus paper test on whether or not we engage in a new initiative. We we always asked ourselves, is this advancing our vision to be the leader in improving child health? And if it is, we're likely to do it. If not, we aren't likely to. And there's some key parts to the vision statement. One is, first of all, a surprise that a lawyer was able to agree to an 8-word vision statement after 2 years of talk, because we have a proclivity to use more words where that's possible. But we did boil it down to these 8 words, and it's really stood the test of time. But the first part that's proved especially meaningful over time is a commitment to be the leader. It's not really good at or a leader or among the leaders. It's a commitment to be the leader in unnamed numbers of components of child health. And the other piece of that was an acknowledgement that leadership is earned, it's not claimed. And our idea behind leadership was what we sought to do is to contribute so effectively to the frontiers of pediatric care that people would regard us as leaders because of the substantive contribution the institution was making. So this wasn't a thing of bravado, it was a thing of commitment to work on improving child health in a way that would be so good and so useful and so constructive that leadership would be a trailing consequence of that effort. And then the second thing that was important about it was a commitment to be the leader in improving child health. It wasn't to be the best or to be any other static thing. It was a commitment which we all recognized would never be met to be the leader in improving child health. And our board chair came up with a phrase late one night that has had good traction over many years, and that is what we want to be is the best at getting better. And there was great power and focus in being able to talk about how do we get better, that everybody's obligation is to advance the quality and effectiveness of what we deliver, and ultimately we defined it more precisely as providing the best quality of life and medical outcomes, the best patient and family experience, and the best value. And this notion ended up being OEV, outcomes, experience, and value were the bywords of what we were up to. And it led us into lots of investments in various things. It led us to always ask the question of what are the frontiers, what more can we do, how do we do it, what resources do we need, where do we get them, all the things that follow. And one of the dimensions it led us to was transformational process improvement, so that we looked at the organization in some ways as a manufacturing facility where we produced a lot of complex results, and all the infrastructure needed to work really well, or else our ability to produce those remarkable results would be severely impaired. So a dimension of this leadership in improving child health very much was a focus on infrastructure and efficiency, dependability, and reliability. And during the course of our developing a strategic plan that followed the embrace of this vision, what we found is the idea of dramatically improving quality and safety, which was coming out of the strategic plan, very much fit the vision. The idea of focusing on effective and efficient systems certainly fit our sense of improved business management, and the idea of transformation for the delivery system spoke to us about what our organization could achieve if it set its mind to it, and that it was very much the right thing to do for children and the families that we serve. And so with a lot of support, we embraced a quality agenda and a family-centered care agenda in the late 90s, and energized by faculty, we wrote quality goals into our strategic plan in 2001, And as a help for that, we competed for Robert Wood Johnson Pursuing Perfection grant in 2002. And it came available just about the time we embraced our plan. And one of the requirements of that was that we embraced this notion that none of us really understood, but of transparency. And we had a lot of talks about that. What we found is that it was often painful and uncomfortable, and a process that we all naturally shied away from, but it was really quite critical. And let me show you the video.
Before his surgery, my mom said to the nurse, "You take good care of him." And she said, "We will." And that was the last smile that we got from him. Safety is so important, and you trust people, and when that trust is broken and something bad happens, you want to fix it so somebody else doesn't have to go through this like we did. And so really I want people that are in the OR, if there's a piece of medical equipment that they don't know how to use, to not feel dumb and say, "I don't know how to use this." Because if they would have said, "We don't have the right machine, we have to cancel it and have it the next day," he might still be here with us. We had 7 months with him. And because of our faith, everybody makes mistakes. Nobody's perfect, and some mistakes cause a bigger impact than other mistakes.
Prior to Tressel's event, we thought if we went long periods of time without anything terrible happening, that was a reflection that we were doing pretty well. And I think what Tressel taught us is that that's not the case. Just because something major or something serious hasn't happened recently, that doesn't mean we're safe. And we need to be paying attention to little things every day. And we've really tried to push the idea, as Tressel's mom brought up, about having a questioning attitude, both for the front line, that I'm supposed to ask questions, I can't ask questions. It's about having the leaders welcome those questions. It's about even leaders asking questions. Is my unit safe? Is my operating room safe? And never having the feeling that we've got it. We want people to constantly be looking for little things that are wrong. And we believe it's from thinking about those little things, making differences about those little things that could potentially add up the holes in the Swiss cheese. And if we pay attention to those little things every single day, that's how we'll prevent another episode like this.
I know, of course, he's running in heaven right now, but it'd be fun to hear his feet upstairs, you know, pitter-pattering, running, playing with his little sister.
I show you that for a couple of reasons. One is to illustrate the fragility of the system that we all operate in. Tressel's death in the hospital was one that was absolutely clearly caused by an error, and it happened years after Cincinnati Children's became firmly committed to patient safety as a priority. The event occurred in 2010, and this safety as our #1 priority really started about in the year 2000. And it happened after we had won numerous awards for safety leadership, the American Hospital Association Quest for Quality Prize, the Joint Commission's Godman Award, the Children's Hospital Race for Results Award, a bunch of them recognizing the really effective and good work Children's was doing. But Tressel's death was a really devastating reminder that we can't ever be complacent, that the system that we operate in, because of its complexity, because of the intervention of human beings and all the things associated with it, is painfully fragile, and that we all need to be vigilant and assertive and courageous about focusing on things that aren't working very well. And Mrs. Marty absolutely wanted us to learn from the tragedy and not have other families suffer from the same loss. The other reason I wanted to show it to you is to show you, at least from our experience, try to share with you our experience of what transparency looks like and feels like. It is tough. It's painful, and it requires a lot of thought and structure to be able to manage well and constructively and sustainably in complex systems like the ones that we all operate in. It means, among other things, engaging families in the work of improvement. It means bringing them onto teams. It means revealing things to them that they wouldn't otherwise know. It means learning from them and respecting their viewpoint and incorporating their experience into new ways of doing things for the institution. And it's a commitment that gave us all pause, but it's also a commitment that we were persuaded we absolutely had to make if we were going to be true to our vision. And my urging would be that it should become a non-negotiable way of life in your institution as well as ours. And clearly, transparency is painful, it's scary, but just as clearly, if we're not willing to have conversations about discomforting data, we simply aren't likely to ever achieve the kind of dramatic improvement that healthcare requires. And the reality is, if the institution discourages open conversation and discussion of these difficult topics and things that don't go well, the probability of it being able to effectively fix those things, change the system so they don't happen again, is greatly reduced. I want to give a second example of transparency, wholly unrelated to our experience with Tressel, and this one relates to our cystic fibrosis program. And I include it because, kind of to my surprise in a meeting I was at not too long ago, the woman who heads the Leapfrog group said, after I showed her an article that described it, that it was the most, I think she said, remarkable story of transparency she had ever seen, and having lived through it, I wouldn't have described it that way, but with her endorsement, let me describe it to you. It's also the subject of an article in the New Yorker on December 6th, 2004 by Atul Gawande, entitled The Bell Curve. And if you want to look further into it, it's an interesting article and well written and adds more data about it. But as part of our preparation for the to compete for the Pursuing Perfection grant, we were required to run a couple of pilot projects to demonstrate our commitment to pursuing perfection and also a commitment to transparency and generally transformational improvement. And we chose cystic fibrosis as one of those pilot projects because we wanted to feature a chronic disease. We thought our program was delivering among the best results in the country. We were proud of it. We had good clinicians, a seasoned program, had plenty of support from the institution. And so we had every reason to think that we were high performers. And as we developed the program, we sought data, or began to collect data, to inform us how we were doing in our treatment of kids with CF. And we studied data, or as we studied it, we wondered how our outcomes compared to other CF centers. And happily, there is a national repository of that information maintained by the Cystic Fibrosis Foundation. And when we got into that data and brought it into the institution, we to our astonishment, learned that our program was at best no better than average for various measures associated with cystic fibrosis, and most alarmingly for lung function, which is one of the major measures for CF. We were at the bottom 25% of the country's programs. And part of our commitment in applying for the Pursuing Perfection grant was transparency. We had already dramatically changed the way we dealt with patients who were harmed, and now we were beginning to learn what some of the consequences of transparency was. And the issue was, how would we address these disappointing outcomes with patients that were not aware of the data? And I've been asked a number of times that people say it must have been a really hard decision, and the reality is that it really wasn't. And the reason was, if we're committed to be the leader in improving child health, which we clearly were, and we're also committed to transparency, how could we do anything other than inform our patients of what we had learned? And how could we earn a leadership position if we weren't willing to grapple with this reality? And so in the winter of 2001, the docs invited the families into a conference room to talk about the CF program. And the families were given the data describing our performance and the performance of the top performing programs across the country. And the docs were very nervous about it. Some of them were opposed to it, simply didn't think it should be done, didn't want to do it. But as a leadership group, we came together and said that we really have no choice. We have to do this. We offered to transfer patients and families' care to any of the other top programs in the country. And we offered to open our program to them to help us get a lot better at what was clearly an enormous disappointment to everyone. The families all stayed, and they all engaged in significant improvement opportunities at the institution, and to the point where now, about 10 years later, we're in the top 10% of every critical measure in cystic fibrosis. But it was an extremely difficult, again, painful process through which we went, but it was using transparency as a tool for improvement. It was enormously effective. And it raises the question about disclosure to patients who have been harmed. We were talking in the last session about it. And the question was, what do we say, what do we do, how do we approach it? And I could use the VA chart to pretty much show our process that we follow as well. But we very much are committed to, within hours or minutes, having a conversation with the family. We did that with the minorities. And we have a standard rule of when in doubt, we disclose. Typically, it's the chief of staff and chief safety officer that conduct these meetings, and they sometimes have with them clinicians that were involved, but sometimes they don't. And it took us a number of years to get around to having a good conversation to really deal with it in a responsible way. And where we ended up without having any barriers on disclosure to today, we use this concept of disciplined disclosure. And the key to it is that we only disclose the facts that we know. And getting to that is not always an easy process. But we want to make sure we disclose all of the facts that we know. And we go through this process and have what usually turns out to be multiple meetings with the family as we learn more so that they can understand exactly what happened. And not unlike the Lexington VA, we invite them to get counsel. We help them get counsel. We negotiate with them where their compensation is appropriate and try to partner with them just as much through the resolution of this process as we do with families coming to us to be cared for disease or illness. And our commitment is to having honest conversation and full disclosure and positive resolution wherever that might take us through the process. The staff in this process also warrants attention, and our psychology department is engaged, our chaplaincy department is engaged, and we try to provide good support for that entire process. The other issue, or related issue, is what do we say to employees about all this? How do we bring them on board so that we're all integrated in the process? And we have a safety tracker system in the upper right corner of our intranet shows the number of days since the last serious safety event and the number of days since the last employee injury. And there's a bar you can click on to get more information about each of those. And what we want to do is establish transparency with our employees so that they know as much about what's going on as we do. And the current CEO has taken that even further, and after an event is completely concluded and we know everything there is to know, he will have an all-staff meeting and describe the whole event, the process we went through, the resolution, and there are often several hundred people physically in the auditorium to listen to that, and there are even more on electronic hookup. But the idea is that we want everybody to know the depth of the institutional commitment to change, and we want to make sure that we fix the system to prevent it from happening again. So I'll stop with the story and just review quickly some key messages that we found at our institution that are essential to if you have a commitment to transformational change and have the institutional will to address these issues. These things are helpful and in many cases essential, we think. First is a vision. Once the vision's in place, that provides a wonderful guidance to everybody toward high aspirations, toward doing things which really matter, which are more important than self-interest, that really, I've often said, speak to the soul of all of us who have chosen healthcare as a career. And they aren't financial, they aren't issues of often in regulatory or other. They're what kind of good could you do collectively using the institutional resources? And it has to be a credible commitment that's based on shared values and can bring everybody from trustees to frontline clinicians around. Leaders have to be courageous. This is not for sissies. This is an effort that requires tenacity. I've said a few times that it requires ruthless tenacity, and it's something pretty close to that. And leaders that don't have that capacity ought not to be leading. We ought to work toward finding the kind of leadership needed get that. The transparency has to be a part of it, we think. Transparency is an enormously important tool, and through a systematic, organization-wide approach to improvement, transparency, you will find, is a great tool, is a great reorienting force among all the people engaged in the process. And then finally, I would urge you to pursue perfection. When we first got into that, my lawyerly mind went to work and said, well, that's not possible, we can't do that. And the more I lived with it and worked with it, the more I began to recognize that it's the only goal worth having. It's unambiguous. It means no errors, no failures, no failure to meet the needs of families and patients, and that's the only goal that I think an institution ought to have. And if the institution is guided by the notion that, well, we take care of sick people and bad things happen and we just can't address those, that's a perspective that permits the institution to not deal with the tough problems, and is a cop-out in my view. You know, we all are responsible for everything that happens in our institutions, whether it's good or bad, and we all need to face up to that reality and act responsibly in support of it. The final point I'd make is that this idea of integrity of message is really important. What we concluded was that we can't, with integrity, say, bring your children to us, we'll take care of them, and then if something bad happens that we cause, go to war with them, clam up, be hostile, be adversaries, and fight with them 5 minutes after the event occurs. And if leadership sends that kind of ambiguous, sets that kind of ambiguous standard, staff can be nothing but confused about when we're really trying to take care of the kids and when we're really looking more after the institution and perfectly willing to be hostile to the patients and families. And so part of what got us to increase transparency was increased sensitivity to how important integrity of message is for leadership to be able to change direction of the institution and engage in transformational change. And with that, the hook is nearby, so I will stop. I don't really want to do a question.
Thank you very much.